right, everybody, welcome back. Now I really get to control the situation here. I noticed that our next panel, I hadn't realized this before, but we get an extra 15 minutes then. So just as I don't know if that's maybe because there's more speakers or because we're really going to stick it to the hospitals in our discussion of this problem. But we have a really great mix of folks up here to talk about hospitals and their role in the problem, but also the role they can play in addressing this issue. So let me go quickly down and introduce everybody. Fred Cerise, who you already met, CEO of Parkland Health in Dallas. Connor Coursey is the Senior Government Affairs Associate at Small Business Majority. Then Eva Stahl is the Vice President of Policy and Programs at Undue Medical Debt. Then Eli Rushbanks is the General Counsel and Director of Policy Advocacy at $4. And I guess when we get into the discussion, I'll ask you guys to talk more about what your organizations do. And then last but not least, Dr. Deepak Goyal is an internal medicine physician who's currently Executive Medical Director at Monument Health, which is a not-for-profit system in Rapid City, South Dakota. So we got into this a little bit in our discussion in the last panel, but I think one of the things that's great about this group is that we have sort of perspectives of folks who work a lot on the patient side and several folks on the provider side. And I thought for starters, we could sort of dig a little bit more deeply into kind of the experience that patients have financially when they go to the hospital. Because just to do a little bit of level setting here, we talked a little bit about charity care, about financial assistance, which, as many of you know, is a requirement for not-for-profit hospitals. It's more of a suggestion for everybody else, but nonetheless, it is common practice that most health systems provide at least some charity care. But I think everybody here would agree that that system is not working well for almost anybody. And so let me start with Eli and Eva to talk a little bit about kind of what you guys have seen from where you sit in terms of why it's not working for patients and how it's not working. So Eli, do you want to start? You work very directly in helping people try to navigate this. So tell us a little bit about $4 and kind of what you're seeing.
So $4 does a lot of direct services with patients, exclusively with hospital financial assistance policies. We have a screener that will screen for eligibility for any hospital in the country. We have patient advocates who will help the patients once the screener has deemed, yes, you're probably eligible at the particular hospital you went to. They'll submit the application, they'll help the patients gather documents, do whatever they need to do, and then all of the advocacy work, making phone calls, submitting the application a second time, a third time, a 10th time to get it processed by the hospital. And then we use our insight from working with these patients to do policy work around the country. What we see is that patients largely aren't applying for financial assistance. Like more than half, I think 51 or 52% of patients who are eligible aren't applying. The largest reason is they don't know these policies exist, they don't know these programs exist, or they fundamentally misunderstand what they are and how they might be able to help them. 65% of patients who are eligible and don't apply just said that they lack knowledge. 23% said that they were confused. Of the patients who do apply, like 14% of applications are never responded to. So there's a host of issues, but the biggest ones are patients don't know, and when they do apply, they can't get through the application process.
Eva, talk to us a little bit about, back up for a second in here and talk to us a little bit about what this is supposed to do. There was an idea here that there should be some regime that would presumably help people, right?
Sure. So I'm on the other end of the spectrum from Eli. So we talk to people as a result of debt relief. So we abolish debt in bulk by purchasing it from both hospitals in the secondary debt market for pennies on the dollar. And then we have an in-house anthropologist who is there to collect qualitative data and listen to the stories of the individuals we help, many times in long-form storytelling. But of course, the way that it's supposed to work is that people have an understanding that they are eligible and know that there is a possibility for some financial assistance when they enter into the system. We find, too, in our data, and we did polling with LLS and ACS CAN, that we have similar numbers that, almost 50% of people don't know that financial assistance is an option. I would just highlight a couple of stories to illustrate this. And we had every Thursday we get stories from our anthropologist. She shares them internally. And one came across the other day from a woman named Christine. We abolished around $700 for her. And she works as a school teacher, and she has 4 children. And she did not know that financial assistance was an option because she was not told about it. But importantly, she didn't think it was for her. And we hear this story a lot, and that's because people are insured. And they think that their insurance is supposed to work, and it's not. So it is this, it is a predicament both in terms of, thinking and believing that this is not something that actually is for you because you have insurance. But also then we had another story the other day from someone working minimum wage, which put them just above the threshold to qualify for charity care. So we also have sort of, and even though this person was insured. So we have this problem, too, of where these thresholds fall, as Kelsey pointed out, where people might just be on the cusp of being able to afford their care and they just can't. So we have an issue of cliffs as well. So, but in its model and in its intention, yes, it is supposed to be something that where the welcome mat is open, is laid down, right, and people can walk through it with ease. But it is logistically very difficult. And I would just highlight, too, that it was not necessarily designed in mind with having so many insured people needing this type of support.
And part of that is just because when we historically think about charity care, right, we thought about this being a system set up when we didn't have as much insurance coverage as we have today, right, and when deductibles didn't look the way that they do, right? Connor, do you want to talk a little bit about this from the perspective of your members? What kind of challenges do they face, and for the people who work for them?
Yeah, absolutely. First, I want to thank you again for having me on here, and so thrilled to be joined by the real experts in this. So, Small Business Majority, for those of you who don't know us, we're a national small business advocacy organization. We represent primarily micro businesses, so the smallest of the small, those with 10 or fewer employees, and solo entrepreneurs as well. So the businesses that are more likely not to be able to offer healthcare to their employees, and solo entrepreneurs we know, and small business owners are 3 times more likely to receive coverage through the ACA marketplace. So it's a large majority of small business owners in that solo entrepreneur micro business space that we represent. And I know most of you might be asking yourselves, what business do I have on this panel representing small businesses? It's because we can't really talk about healthcare without talking about small businesses, because the rising cost of healthcare is the #1 concern of all small businesses, or at least the ones in our network. We do national polling consistently that small business owners rank the rising cost of healthcare as their #1 barrier to sustainability and growth. And when you account for all the other barriers to growth that small businesses encounter, that's quite a damning statement. We've heard obviously the impact, or argued the impact of medical debt on credit reports. For example, Patricia earlier in the panel noted that the CFPB's effort to remove that debt from medical reports. We know that majority of businesses use personal credit in some form to get financing for the business. So the more likely, so when you pair rising healthcare costs, that puts more small business owners and their employees at a greater risk of medical debt. Pair that with the impact that debt can have on a credit report that ultimately impacts their ability to secure financing for their business. Just in recent months, we've talked to 2 business owners. One from Chicago who noted that her and her family recently incurred $60,000 worth of medical debt in the last year alone. She had to refinance her house or her mortgage, and she noted that she's going through a large chunk of her savings. Another business owner, she noted in 2016 that she had to declare bankruptcy because of the amount of medical debt she incurred, which completely wrecked her credit score and really put her business on hold for a number of years. And to kind of echo what Eli and Eva were saying, they just business owners just don't know about the assistance programs that are offered to them. So I think there's a real, lack of knowledge, and I don't know if that's accounted for by the hospitals, a lack of outreach efforts to the community. But I think business owners increasingly, pin the rising cost of healthcare on hospitals. So in a sense, they think the hospitals are out to get them. So it's understanding why they wouldn't, think to go to hospitals for healthcare assistance, for medical debt assistance.
So we obviously do a lot of beating up on hospitals, which is fun. But there obviously are reasons why the system looks the way it does. And at least speaking from my own perspective, having met a lot of hospital executives over the years, they generally don't have sharp teeth and tails and what have you. But Fred and Deepak, can you talk a little bit about when hospital systems think about this system? And let's start, I guess, with charity care, and then we can think more about patient balances in general. How are they thinking about this? And it must not be a secret that this system's not working, but it's obviously not getting solved. Deepak, you want to start?
Okay, I'll go first. So there's I'm sure there's several things going on. One is, believe it or not, there still is some level of lack of awareness about these billing practices and the impact that they have. If you read Luke Messick's book, and he talked about going to his hospital CEO, and he's an ER doc who found out that his patients were being sued by their system, and he went to his CEO, and he wrote an article about it, and his CEO brought him in and fussed at him and said, that's not true. And he said, well, in fact, it is true. Here's all the court records, And so I still think today that there's a lot of people who they're just doing business. And, if you go to those rev cycle people, this is what they're trained to do. They're trained to collect. And so a lot of times I think that the leadership of the hospitals are not even that aware of the details of these the collection practices. I know when I started talking to you and diving into this a bit, I went to our own rev cycle people and said, tell me we don't sue people. Thankfully we didn't sue people. But as part of our collection practices, at some stage when we don't sell debt, but it would go to an agency at some stage, and they would report to credit agencies. And so I didn't know that. So now we don't. But I'm probably more interested in this than 99% of hospital CEOs. And so I don't know that there's enough awareness there. I mean, that's so our fault. But I think that's part of it. Another part of this, though, is we work in this system where, for all of us, perhaps for different reasons, but we still have to have patients prove that they are worthy of some kind of discount or free care, right? Other hospital systems may have their own reasons. I work for a county system. And so we need to show we tried to find a funding source for someone. Are they eligible for Medicaid? Are they eligible for insurance? Are they eligible for the exchange? If they're eligible for the exchange, why haven't they applied for the exchange? And what are we doing to make sure that they have coverage that they're eligible for before they come to the county for the funds of the county to support their care, right? And so it makes it complicated. If they haven't applied, why haven't they applied? Well, they're in between eligibility periods now, enrollment periods. And so they still need care today. Every hospital is going to provide emergency care because you have to. But they're not going to provide the other stuff that you don't have to do to treat and stabilize, which I think is a big piece that we haven't talked about yet. But that is, someone has a mammogram that's abnormal, and they're in between enrollment periods. This idea of application for non-emergent or elective type stuff, that person is generally not going to get care unless they come up with their portion of the copay or their deposit up front. So if they have an abnormal mammogram, they're not going to get that unless their extra views or their biopsy. And if their biopsy is positive, their chemo and their surgery. So these are all kind of barriers that are put in place. by, again, the fragmented system that we have. And so hospitals are they're going to look to, for their various reasons, to see what are the other possibilities of payment. For me, it's the county. For someone else, it might be their shareholders, to try to ensure that they've exhausted all that before they go to this charity care piece. And that ends up becoming a big burden on patients along the way. And you have different practices like, well, let's not advertise that we do this, because if we do that, we'll have less success up front. And so it creates a lot of sort of, dysfunctional behavior.
Does that jive with your experience, Deepak?
Yeah, first of all, thanks for having me here. I'm honored to actually be sharing the space with experts and the great work you're all doing. So I work at Monument Health. We are a healthcare system in the western South Dakota with our patient outreach into Nebraska, Wyoming, and Montana. And I'm a doctor, so I love to diagnose and treat. And I got myself involved into rev cycle management almost 4 or 5 years ago. And I diagnosed that our system is suffering from a phenomenon called tragedy of commons. Anybody aware of that? So that was an economic theory. When people think that resources are plentiful, even rationally, they tend to, as Dr. Sani had said, we care for patients, but also we do things to them, and without the mindfulness of cost. And the system we have is stacked very, I think, oddly against the poor people who actually deserve all the system that we have set up for financial assistance. They don't have a negotiated rate. They don't have, advertise that you have all those things lined up, even though it's mandated by the federal government. And what I came to realize that those patients are suffering almost unbelievably high as compared to the rest of the population. So I took on myself to design financial clearance process, which he was talking about, where clinicians make decisions as to how the care will proceed and how the financial aspect will be decided. And that's where it led to my discovery of that, how fragmented the system is. We have, this initiative of charity care or financial assistance. Per se, charity care has almost a negative connotation to it. The financial assistance program we have, it has been pushed to a corner, like the very far end of the whole management. Actually, it is a part of the clinical care. When the patients have unpaid bills, they're not going to follow with the doctor when the care is needed. Then that care gets pushed to emergency care. Then that is way more expensive than the regular care. Then it gets to more medical bills, more bad debt, and it also creates strain on the people who are actually financially able to pay, the payers. So it's not a moral imperative that we have to solve this situation. It is a strategic advantage, in my opinion.
And so just to build a little bit on that, as you were trying to engage in this, what was I assume this took a little bit of time. What did you run into? And I mean, why your hospital, Fred, your hospital, most hospitals are set up to help patients, and yet here's a system that is clearly not working for patients. Why couldn't you just snap your fingers and fix it?
Hospitals get undue blame that hospitals are not doing enough, but there are some barriers which we have to understand. I would think there are 3 things that are creating those barriers. One is resources. It takes resources, and hospitals are already cash strapped. Where to deploy resources? There is so much of variation in interpretation of the rules from IRS. There is a regulatory burden onto that. Hospitals are concerned that if I say go above and beyond, is somebody going to come after me and going to say that it's an inducement? So that's another thing. And third, obviously, there is a financial constraint that, if we let go of this program or if we go above and beyond, is it going to decrease our collections? Is it going to create a challenge for financial sustainability? I think all CFOs would have concerns. And we have removed the clinicians, doctors, nurses from this process of discussing finances with the patients. First, they don't have time. Secondly, we don't want them to talk about money. So that we have an inherently disjointed system, in my opinion.
So, Eva and Eli, do you want to jump in here? You've worked with a lot of health systems in different contexts. What are your observations about what's stopping them from making this system work better?
So I would concur with that. That's a lot of what we hear is, there's regulatory constraints, and I think there's a lot of concern around revenue. And I think that, if we look at what's happening right now in the district, right, those concerns are just going to continue to increase. We actually are working on a small project with the Healthcare Anchor Network where we're convening a set of hospital systems to bring together leaders of revenue cycle and leaders of community benefit. And in those conversations, we're learning a lot about how these groups don't often communicate with each other, but need to because they don't speak the same language and they don't always share the same goals. But they can find solutions that we're finding where they can actually both reach their goals. And that's maximizing revenue where it makes sense and also making sure that you're addressing community need, because I don't think that they actually see each other and don't see those things working hand in hand, and they actually can. But there is a lot of fear around revenue, and there's a lot of fear around moral hazard, which is the inducement piece, is mostly what we hear.
Eli?
There's definitely a lot of shitty lawyers saying no when they should be saying yes. So I'm definitely going to agree with you on that.
So the lawyers have
Yeah,
chance.
I'll be the self-hating lawyer in the room. You all don't have to do it. Yeah, and I think there's a lot that Dr. Cerise talked to about the executives in the room not knowing what's happening, but there's so much. It seems like from the outside looking in, it seems like there's so much siloed off sections within these organizations. I mean, these even like a single hospital is a pretty big operation, and the revenue cycle folks are churning along doing what they do, and the doctors are off churning along doing what they do. The accountants are off like doing what they do, and these entities, like especially in the rev cycle space, I'm maybe like struggling to figure out the words here because it's so they're looking at all this from such a 1,000-foot disconnected view from the actual patient. Like the doctor's seeing the patient, the revenue cycle person isn't seeing the patient. They're not even really the billing department. That's like a whole other separate group of folks. The revenue cycle folks are, you can see it in the terminology that they use, like revenue cycle management. I mean, what they're talking about is like charging people and collecting the money. They use these terms like charge capture, which is just like, another term for that could be price gouging. They use terms like reductions in accounts receivable. That's just squeezing more money out of patients. So they're doing their job, and they're probably doing it well, and like that's part of the problem. There's this problem of, I don't even necessarily want to say it's a problem of incentives because I don't think anyone's telling them to do that. It's more like a problem of inertia. Just no one's stopping them from doing it, if any of that makes any sense.
I think it does. So maybe can we differentiate between kind of real versus perceived barriers? Because I think it's worth maybe, I know this is a very knowledgeable audience, but maybe going a little bit further into the problem of inducement, which, I mean, there are laws in Medicare and insurance contracts that dictate sort of cost sharing and the requirement to bill. I mean, that seems like something very real. I also find talking to revenue cycle management folks that sort of everyone has a story about some tech bro who's going to roll up in his Ferrari if you don't charge the $150 dollar copay. And my sense is there are not that many of those dudes out there, but maybe not. But like all of you who sort of work in this system, what's real and what's imagined here in terms of barriers?
I mean, I think there are innovative things happening, and I think that that some hospitals are sort of catching up, and that they can overcome some of these barriers. And I think we can talk a little bit about presumptive eligibility and what are those tools and how they're being deployed. But I think what you can't escape is the increasing complexity of the landscape, right? So I think that Patricia put it really well. Like, this is crazy complicated. And the way that the workflow, if you really want to get down and dirty and you think about revenue cycle and how the workflow actually operates, when a patient walks through the door and they're uninsured, it's a simple sort of, oh, we should move you to financial assistance, or we should at least try to screen you and move you swiftly into financial assistance if you're uninsured and you qualify under the income threshold. If you're insured, there's an assumption that you can pay. right? And so it's much later in the workflow when you're going to try to figure out whether somebody may or may not be eligible for financial assistance. And we have to figure out, and we can figure out how to get over that hurdle. I think that, where the conversation is shifting, which is, I think, healthy and important, is around what is needed. Everything's anchored in income, right? And we've asked hospitals to be income verifiers. That's something usually the government does. So it's just, I think it's important to recognize that hurdle and think creatively about how to address it.
So Fred, Deepak, is that a real burden that you as hospitals need to be in the business of assessing people's financial wherewithal basically on a every patient basis?
It is like the worst part. It's the thing that drives me the most crazy at our place is that. Because our doctors, they just want to treat people that come in, right? And then this idea that you've got to be responsible and be able to sort of verify that somebody fits in the right bucket to be responsible and take care of them. And so this issue of having to verify income, to prove income, creates just an endless amount of work that ends up delaying access. And you'll hear stories like, I had a nurse about a year ago in one of our clinics who was lobbying for, we'll get these special cases to then change our policy around a special case. And, she told me the story, some woman who came in and said she needed a particular procedure. And she said, I can't document my income. Everything is in my husband's name. He gets paid in cash. I'm not going to be able to document that, right? And so that's one story, but it, multiply it times 1,000 times, because with whatever level of complexity these applications are. So yeah, it's a real thing, and you end up, like we do these endless workarounds. The doctors figure out workarounds. They'll admit people to the hospital from the ER that don't need to be admitted because now they're in and they're going to get their stuff done because they're afraid if they say go home and follow up in clinic in a week and we'll address this, then that they won't get past the financial screen. Some of them legitimately, a lot of them not legitimately, but they don't understand the process. So, it creates dysfunctional workarounds as well. So, yeah, it's a big piece of what we do, and and it creates barriers.
I completely agree. Is it working? I completely agree. The thing is, we have created a system, and again, there is no point in bashing rev cycle people because they are doing what they're programmed to do, right? That's a system we designed, the system we created. And what we did at our place, we recognized all those things. Again, I'm not trying to come up with solutions. What I realized is there is a variability in understanding. The clinicians understand when we say the word financial assistance, they have a picture in their mind that might not align with the picture which operations have in their mind, which might not align with the picture which billing people have it, or it might not align which a CFO has in mind or the lawyers have in mind. So we created a very one-page algorithm from the very start that service emergent or urgent. If it is emergent or urgent, money is not the matter. We provide service. But if it is elective, we go through this algorithm. Patient has insurance, no insurance, qualify for insurance, ACA, does not qualify for financial assistance, qualify for charity care, end of story. So I think the point I'm trying to make is the more we move this process to the front side, align with the clinical care at the first point of contact, not all the way to the back. I think this is where a lot of disjoint lies. So we beat this idea to clinicians, to our doctors, to our operations people, to our logistics, to our rev cycle. So everybody's on the same page. I think that's where the change starts happening, in my opinion. And that's where the cause of and even at a fundamental level, it starts at the medical schools and nursing schools. We are not taught. There is no class on finances or patients' financial assistance in medical school. I've been to 2 medical schools and there is none. So I took it on myself. Actually, I took a class with the medical students. On 3rd year, it does not get tested on USMLE. But I took a class and I'm talking to the dean of the university that can we make it something that clinicians are aware that how to help the patients.
So I think I mean, not surprisingly, when we're talking at an event about American healthcare, complexity comes up as as a major barrier. I mean, so are we agreeing that a simpler system for assessing patients' ability to pay their bills would go a long way, probably, to addressing at least part of the problem, right?
Absolutely, the simpler we can make, because what's happening is, the guidance is that you should have a financial assistance program and a policy, and it should be on your hospital's website, and it does not absolve people of the responsibilities that, once we have done that, is it the end of the story? How do we apply those rules? I think that becomes to an individual level and individual hospital level, that how do we interpret those rules and how can we go above and beyond? And also there is no incentive, not even a recognition, more fear that if we do something, are we going to get caught in this jam?
Eli and Connor, both of you talked about sort of the challenges that patients have filling out this stuff. One thing that I've always wondered is, what is the rationale for having all these different standards for applying, not only qualifying, but then applying?
I'm not the one to bring rationale to the system.
Well, that's why we have you on the panel. But I mean, the part of this exercise is waving a magic wand. And is there a reason why there shouldn't be a more standardized system for getting assistance?
No, I think there should be a standardized system. I mean, I don't know if there's anybody who works for government agencies in the room. Probably. I'm not going to ask you to raise your hands, but please just start opening this data up for hospitals to use, tax return data, Social Security data, who's already enrolled in Medicaid programs. All of this data could be used to screen people for eligibility for these things. Right now, all of the burden is on the patient to learn about these things, to gather all these documents, to get through this whole gauntlet process that takes our trained patient advocates often months to get through this process at the hospital level for all these reasons we're talking about. If there was just an API where they could just, the hospital systems could just check at intake, against government data, is this person eligible? It would not just solve this problem, but a whole lot of other means testing issues across the country. So I guess if I can, grandstand for a second and advocate for that. I don't even know if this is answering your question.
No, it is, absolutely. I want you on the grandstand. Yeah, go ahead, Fred.
I think that would go a long way to one part of the problem. Now, the other part of then you've got the data, so you can make a determination. The other part about standardizing, what are the expectations, would get a lot more people into the game at that point. Because right now, the example in Boston where if I'm Beth Israel, do I want to put up a billboard that says up to 106% of poverty, you're good here? Or if I'm at Brigham and Women's, do I want to put up a billboard saying at 106% of poverty, you're good over there, right? And that's what, whether it's valid or not, every one of these rev cycle people are going to tell you, if we make it too easy, then people are going to selectively come to us, and it's going to be a disadvantage. And so if you had some common standard, then you take that away, and I think you'll get a lot more uptake quicker.
But in fairness, then you also have the rural hospital that says, I can't be up to 400% of the federal poverty level because that's my entire community, versus, a more city setting that might, it make more sense. So we hear that a lot too.
Yeah, absolutely.
And certainly that, setting uniform standards has been a subject of quite a lot of debate in some of these states that have tried to set minimum standards. But I mean, what can we say about have we learned anything so far in those states that have in fact set floors? Or, I mean, many of these states that have done this have rural hospitals. They also have Cedars-Sinai on the west side of Los Angeles.
I mean, I think that's more of a Fred question.
Well, I mean, I can say, you certainly have groups with very big differences in what their capacity is, and so that's another. Now you've introduced a layer of complexity into a standard. But what is that? And then you've got, every state has pays hospitals for uncompensated care in some form or fashion, and oftentimes, if you look, it has no relationship to the amount of uncompensated care that the hospitals are delivering. And so, I would, now we're just making it up here, but I mean, you have some levels of standards that you match with your uncompensated care policies and reimbursement policies that cover a portion of those costs. One of my frustrations with just in general with our sector, organized medicine, hospitals, doctors, is we've traditionally opposed universal solutions, right? You go all the way back to Medicare, where we've opposed universal solutions, and then because we love the private market and optional services, but then the people that fall out, we are going to look to the government to pay for that piece, and we don't want to do that, and because we need to get paid for it. Now there's something there. You've got rules like EMTALA that say you have to treat everybody that comes in the emergency department, but by the way, there's no rule that says they're all going to be insured or that you're going to get reimbursed for it, which ends up feeding more of the dysfunction and the high cost because now we're going to cost shift and all that. So I think you have to look at perhaps categories of what hospitals, what standards you can apply, but then on the reimbursement side, if you just do this without paying attention to that, then you're going to have a revolt and probably not get anywhere.
I mean, the related question in terms of standards and behavior has to do with collections, of course, and states have obviously made some efforts to limit more aggressive kinds of collections too. And this also goes right at a perception by hospitals and revenue cycle management people in particular that if you don't have a stick, people aren't going to pay their bills. What do we know about how real that perception is? Anybody?
It's not real. I think there is some truth, but not as much as as is perceived. So we have this that people, once we have this, if we make this too easy, that people are going to abuse the system, or all the people who are into some sort of financial assistance are gaming the system, and that's not true. So when we looked at our data, I don't know if I'm supposed to share or not, but our collection rate was 10%. After the account has been turned to collections, it was 10%. It means one thing, that 90% of people are not able to. It's not a question of willing to. It's a question of able to. They are poorest of the poorest people, and all those challenges that have been highlighted, complex process, patient-initiated process, lack of knowledge, and all the hoops, the asset testing. Some of them don't even have a permanent housing, and we are sending them the bills in mail. How do we expect them to follow the system? So this is where I think, from my standpoint of view, and our hospital is not special in any way or form. I think when I say 10% collection rate, I am assuming it probably applies to all other hospitals. There might be 2 standard deviation left, right. So this is the amount of, I think, problem we are dealing with.
Anybody else want to weigh in on the real or perceived problem with patients not paying if they don't face dire consequences?
So we hear from patients all the time, like we're the ones pushing patients to apply for financial assistance. By the time they found us, they are often pretty desperate. We have patients push back on us a little bit, largely out of shame for not wanting to pursue financial assistance. In fact, 10% of the people in a survey that we did who were eligible but didn't apply for financial assistance reported that the reason was that they were ashamed to apply. So the idea, from what we see from working with patients, we worked with, 35,000 patients or so far. It doesn't track at all that these are folks that are just trying to game the system or get out of some bill that they could otherwise pay. It's often a very difficult thing for them to do, to raise their hand and ask for help.
Fred, you said you stopped credit reporting once you learned that you did that. What happened? Anything?
Yeah, I don't think anybody noticed. I really don't. We didn't go back and look. You know what I mean? We just, whatever our collection group was, we just said, don't do it, and cut it out.
But the CFO didn't come knocking on your door and said, Fred, what the hell are you doing here?
It's interesting, it's because we're about to run another experiment in our oncology clinic where, do we really need to sort of re-up people for eligibility while they're undergoing courses of therapy. It's going to take several years because you're not going to stop anyway. And we want to look to see what kind of impact something like that happens on your actual ability to collect, because we just, there's so much of what we do that probably your bang for the buck is very little. But we haven't studied it a lot.
We started a program. I don't know if it is the right platform to talk. Presumptive charity care means we started an automated system, and we noticed a difference. We have not been reporting our patients for almost 4 or 5 years to Credit Bureau, and we noticed this change of, it's not a lot, but 2% change. Our collection has gone to 2% higher. So it means that we were screening appropriate patients, and that was a concern my CFO had, that are we going to decrease our collection? And once we have this, I think everybody felt encouraged that it was the right thing to do from the start.
I mean, I think that's the point, right, too, is what are people actually able to pay, right? So we see this a lot in our data as well. So as you know, that when we buy a portfolio of debt, the majority of folks in those portfolios qualify for our program, which is under 400% of the federal poverty level. So, we see, I think we also need to be having a conversation of what, to Connor's point with small businesses, like what are people actually able to pay? Because a lot of people are being stretched and pushed when these thresholds are too low, right? And they're put into categories that, they can't pay these bills. And I think that's a concern with the growing rise in payment plans too, right? Is that people are entering payment plans when they couldn't actually pay in the first place.
Connor, let me ask you a little bit to follow up on something that you mentioned earlier about the way that some of your members actually think about hospitals, because that's something certainly that struck me in my reporting. I still remember interviewing a patient in California who, after going through some nightmarish billing experience, said, "I feel like the hospital's a predator, and like I'm not going to go there." Are you picking up on this feeling that people no longer see a hospital in the same way?
Yeah, I think so. And I mean, if you think about it, I think it makes sense. There you have the most face-to-face interaction with hospitals. You think that you're giving hospitals their money as opposed to the insurance companies. But in the past, actually, we've asked this question in Cerise for multiple years, and it has usually been, obviously, insurance companies are bearing the brunt of the blame, but now hospitals have steadily risen as well alongside that, along with the drug providers, of course. So I think it is interesting. I think, and we know around 50 or 60% of small business owners said the cost of their hospital visits have increased year over year in a survey we did last year. So I think it is, their face-to-face interaction with hospitals definitely plays into that. And I think, obviously the costs are rising, right? And, they're getting the bill from the hospital, or so I think that's kind of where their sentiments lay.
I know I want to get, I'm sure a lot of you have questions, but one last question to throw out to all of you guys. And again, I'm picking on our 2 hospital execs here particularly, but open it to everybody. I wonder, from a sort of advocacy and strategic standpoint, whether when we think about what would actually change behavior on the part of providers, I think there's an assumption in the media, I think, that, well, if we keep writing stories about all the terrible things that hospitals do, that will prompt people to, stop suing or stop putting liens on people's homes. And I think there's some evidence that happens. But it's also true that all of this negative attention, I think, can also foster something of a siege mentality, right? Where well, why is everybody picking on us? And we don't design high deductible health insurance plans, and may make it even less likely that people in the hospital and the provider community are willing to listen and willing to engage in a discussion about this stuff. And I guess I throw it out to everybody. As you think about, one of the reasons for this gathering is to brainstorm ideas and think about how we can have constructive conversations with all stakeholders. How do we walk that line?
So I think the hospitals get a little bit of this unfair treatment in a way by saying that, hospitals are predators. I think it's going too far, because people who work in hospital, everybody wants to help. And this definition, very definition of charity care or financial assistance, it is defined by IRS, but most hospitals have to go beyond, above and beyond for that. The term is community benefits. You need to, for example, we need to have a neurosurgeon on call, and there might not be a single case of head injury. So where does that money go? We have to maintain capacity in the hospital. So those things also go in community benefits. I think hospitals get this, and there could be this mentality. When you have this negative press against hospital, they tend to dig in their heels. So the solution, in my opinion, is again education, because people want to help, but how to help is a question, and that's where discussions like this play a big role. When we have business, hospital business people, executives, clinicians, policymakers, advocates, I think all in the same room, solutions would come. And we took a small attempt in our hospital to make a small change. And there is actually a strategy called oil blotting strategy. It's when you're an insurgent, how do you make a change? And maybe at some other time we'll talk the details. But once the change starts happening, and I see this change happening right here in this room, and more hospitals will learn and things will get better.
Anybody else want to take a shot at this?
I mean, you're asking from a hospital perspective, what would get people to engage? I've reviewed a number of responses to you, Noam, from hospitals that did not appreciate your stories. So that pressure campaign, I think there is something. There's something to be said about raising awareness. I mean, and that is effective up to a point. But I do think you end up with that siege mentality of this is we're why the hospitals, because there's so many other things contributing here, right? There's the insurance companies, and there's drugs, and there's you name it, right? There's a lot of other pieces to the system, and so it creates that that mentality. So how do you break through that? That's a tough one. I mean, I think because ultimately, in you say hospitals, but hospitals, as Eva just pointed out, that's a very broad range of things. You've got places that really do struggle and can't afford to not get paid. In Texas, we got probably more rural hospitals going out of business than anywhere else in the country. And so you do have that end. And then you've got, like in Dallas, which is a very expensive market, and some big systems doing very well. And so, that's the spectrum. So, how do you engage hospitals? It's it's not a homogenous group from to start. But then I think pulling in the other players too, which is very difficult because part of the price escalation is the insurance company, hospital, competition that goes on there. Hospitals acquire scale. Who talked about antitrust? Because I think early on, we create scale so we can drive, get market share, drive prices up. But ultimately, you're going to continue to have the hospitals will say, well, it's not. Why do you come to us and not the insurance companies or the drug companies? It's always the ability to point elsewhere. And so, without including all the different pieces and the fact that we've got after all the pieces are included, we still have a health system in this country that leaves out the significant chunk of people who are either uninsured or underinsured, and then that becomes a health policy issue. So you've got to include that in the discussion as well. So I guess to get hospitals engaged, I think pull another, the group to the table, and then we'll all point to the government, I'm sure, and say that's the problem.
Eva?
I would just add one more, which is clinicians. I think that clinicians have a role to play. And we did a number of focus groups with clinicians last year. And I mean, they're very frustrated and overwhelmed because they're so close to the issue in dealing it with their patients. And I think that much like you've noted around being a clinician yourself, right? Like bringing that financial experience into those conversations. I know that some are very adverse to that, but I think that that's part of people's health is their financial security. And so finding ways to have more of those conversations, because physicians have more power within the system, that they can be influencers and important messengers. And then I would say second, We also need to find those best practices and encourage hospitals to share them, because they're often under lock and key as they try to figure those out. And that's because they're afraid of showing up in one of your pieces, right? So it's also trying to make sure we're creating those spaces where we can figure out what those things are and celebrate them so that they can be replicated.
Either of you want to jump in? Eli?
This comment isn't going to make the policy work I do any easier, but I think getting individual hospitals involved in policy conversations and getting the hospital associations as far away from policy conversations as we can, I think would help a lot. When we're working on bills, it's usually us and a bunch of advocate groups, and then there's the hospital association on the other side. And when that's the framework, it forces the hospital, so the entire hospital association to have like one stance and one position. And as we're hearing, it's a very diverse group of folks. I mean, that hospital association has to represent the large, massive nonprofits, the for-profits, the rural hospitals, and distill all that down into like one single position. And I think it leads to extremely watered down at best and ineffective policy at worst. So just bringing more, I don't know whose responsibility that is to get those voices in the conversation more, but that would help a lot.
Anyone with the last word?
I don't know about the last word, but I'll agree with Eva and Eli. You know, as an advocate myself and at Small Business Majority, we try to give the microphone to the small business owners as much as we can, and I think that holds true here as well. Bringing clinicians, bringing patients, bringing hospitals with success stories on financial assistance programs to the table as much as possible, and shining a light on those success stories, those best practices, on the impact this has on clinicians is obviously would do wonders for spreading awareness and providing examples for other hospitals and networks around the country.
All right. Well, I know we're standing between you guys and food, but I'm sure there are some questions.
We're down a couple microphones right now. So they're doing a tech reboot at lunch, but for now, if you can use the podium mic, and I'm going to run this around for folks. So, okay.
Hi, my name is Kelly Folkers. I'm a health attorney at the Community Service Society of New York. I have helped hundreds of patients apply for hospital financial assistance, saving people millions of dollars in the last 2 years. I just want to address the framing on hospital financial assistance in this session, which is not specific to what I've seen here today, just in general. I really dislike the term charity care. I don't like references to people gaming the system. The reason for that is hospital financial assistance is a legal obligation under the ACA and multiple state laws to help middle and low income people. When I tell people this who have insurance or who are uninsured and who have shame, it immediately evaporates because they understand this is a right I have as a consumer and people want to be treated fairly. I think that's a core value in this country that is eroding, but there is a real need for more procedural justice, and that is what hospital financial assistance is. Everyone has the right to apply, even people who aren't presumptively eligible. There are ways that they have a right to appeal. They have a right to explain their circumstances. So I think there's a really big disconnect between how we as consumer and patient advocates and then the people that we help see this and how hospitals and certain other groups are seeing this. And at the end of the day, this is a legal obligation to help people. It's not charity. It's not a system that can be gamed, really, if it's done fairly. So I don't really know if I have a specific question on that. I just wanted to point out our experience with this and also just, see if there are any responses to this framing and if there are any ideas about how we can bridge this gap between what we in the advocacy community are saying and how hospitals and other players are seeing hospital financial assistance.
I think it's more of a statement, and I completely agree.
Hi, Vardhan Shmamian from Los Angeles County DPH, leading our efforts on improving financial assistance in California. And we did that, just brief background, multi-pronged approach, immediate debt relief, working with Undue, connecting with people such as Eli, Dollar4, and other national stakeholders to get feedback on how we can improve the systems and set up a best practice committee that's coming up with uniform model documents for hospitals who want to voluntarily use it. But what I was going to say is the biggest thing that gets lost in California, we have a minimum of 400% of FPL, and it's publicly subsidized. So you save money on property tax, sales tax, and other incentives. So you have this social construct of, hey, we'll give you these breaks, but if someone can't afford their care, you'll operate in good faith. So, and just to ask Fred a question, what was the financial difference after stopping suing people? Like, was there a noticeable difference when you stopped going after patients?
Well, we weren't suing people, thank goodness, but it was reporting to credit agencies, and they said we didn't notice a difference.
So I've been asked to, I think, I've been having discussion with my friend here. And so the impact we had, after we started a program called Presumptive, again, I don't like the word charity myself, but it's a universally accepted term. So I have to use that, presumptive charity care. So what we did is we added two systems. One is a state-guided FPL, Federal Poverty Guidelines. Secondly, we created an algorithm working with the Collections Bureau because they have tons of information. They were our data, trove for me. So we created a system that is basically screening out patients. And the moment I find out that had this patient applied for charity care would have qualified, we basically write the whole thing off. And we have helped since inception in August of 2023, 5,265 lives that have been affected positively or impacted positively. So there is a lot of value. I think that was your question, by the way. And no, it's $15.6 million worth of dollars we have written off. I'm not again sure I was supposed to share or not, but that's a number we have as of yesterday, and it's growing every day. So that data point I've not tested, but I'm pretty sure there is a lot of, this opportunity cost is basically you're asking. So we did not calculate that, and I don't know what's the best way to calculate that. But what we have found is our collections have increased. So it means we were screening the right patients out to the right box.
Barack Richmond, Georgetown Law School, I'm sorry, GW Law School. God, my colleagues will be upset that I made it. And our graduates also. So I wanted to build off of something that Eli said about the political dynamic. I agree with him 100% that it's quite dysfunctional if you have the hospital association negotiating with everybody else. So two questions. One is, what's the relationship, I guess it's a question to Deepak and Fred, what's the relationship between your hospitals and your state hospital associations? Are there any opportunities to either, I imagine you're not big enough to affect the initiatives, but is there any way to perhaps noisily deviate from them? And a similar question to Connor about the relationship that his organization has with the chambers of commerce, which tend to be dominated by local hospitals. And that's something I've never understood, because the interests of the local hospitals tend to be fairly diametrically opposed to the interests of the rest of the economic community. So those are two possible ways that we could shake up the political conversation. And I was wondering if any of the three of you had any plans or experiences doing that.
So I've been in some of the conversations between the chamber or chamber-like organizations and the hospitals, and they tend to be very polite and not get at the consequential issues, because the hospitals are obviously big employers and big business, and so when they're in the room together, I noticed that with the business leaders, it just doesn't get down to like some of these core issues that are conflicts, as you note. In terms of being able to move or influence the hospital associations, we are not members of every hospital association that we could be members of for some of those reasons. I think they're just too broad and try to represent too much and too big of a point of their advocacy positions don't necessarily line up with ours. So so we're not a member of everything. The ones that we are, like your friend Steve Love, who's a good person who goes into the C's mentality. We have these conversations of the Dallas-Fort Worth Hospital Council. Good person, but has a very different point of view on this, basically why you're attacking hospitals, right? So yeah, we have these conversations, but generally, we're not past the C's mentality.
Hi, go ahead, please.
I can add, I work at the federal level, of course, and I'd have to ask some of our state folks, how they are interacting with their local chambers of commerce. But I think generally we tend to have, a disconnect with, what chambers of commerce are advocating for versus what we are advocating for, just because I think some of the structures of the chambers and, what businesses they truly represent. And I think there's a disconnect because, being the smallest of the small businesses, the needs of those businesses aren't always elevated in chambers, especially with the U.S. Chamber, I think. So there's disconnect on that way, but on that sense. But it's a good question for my state directors that I'll take back to them.
For me also, I think this is a take-home point for me. I'm going to take it because when I get started on this thing, I didn't think of this, that it's going to get some sort of, that I'll be here. I just set out to make some difference in the lives that the patients we were serving over there. And but this is a good take-home point. Thank you.
Hi, and I'm Bethany Prey. I'm at the Colorado Center on Law and Policy. And we had a sort of question about enforcement, state level enforcement and implementation of those discounted care or charity care programs. And what we've found is we don't have much. We have some reporting that's very incomplete and not so accurate. Our colleagues at the Colorado Consumer Health Initiative did a survey of hospitals where they called to get information, and only about 11% of the hospitals gave complete and accurate information about our statewide discounted care requirements. And for Spanish speakers, the number was much lower. It was 3%. So, we know it's really hard to get that information. And then one other, comment really is that I think that all this discussion also points out to waste in the system. I mean, there is so much waste that goes into having to screen everybody, having to bill them, having to send them to collections, having to, the scheduling even, because when people call and they don't have coverage or they have a debt, they don't get scheduled. So there's delay in care. I mean, there's all this waste also built into this, though that's not the way currently waste is being discussed.
Change is never sudden. It happens slowly. And, these discussions have started. I'm very hopeful that change, and I'm an eternally optimistic person. I'm hoping that change will happen. And that tragedy of commons I mentioned earlier in this discussion, there is actually a solution. So it was given by Miss Elinor Ostrom. She was a Nobel Prize winner in 2009. So she gave the theory of managing commons or governing commons. And the solution lies in that theory which she gave. I think you can just write down, search on Google. So it has to be a mix of governmental regulations, plus also the change has to start happening from inside. Because if it is just governmental regulations, it won't happen. People will always find a way around. And so that would be my take on that one.
I think go ahead, Eli.
I was just going to, on the question of enforcement, there are a lot of this is regulated at like an ND regulation level, where it's rules for the hospital to be the specific type of entity or have a specific type of license. And there's another way to look at this, which is just a straight up consumer protection issue. And the enforcement mechanisms that are common in those two like legal approaches are generally different. From the entity level, it's usually some government agency who's checking boxes and seeing if someone filled out the right form, or in the case of the IRS, that's just not happening at all. But with consumer protection statutes, it activates Also government entities and states, attorneys generals, and then it opens up more like private enforcement by the plaintiff's bar, which let in this case, patients stand up and actually enforce a lot of these rights if we think about them as consumer rights as opposed to like a healthcare entity thing. So there's a lot of talk in this space around what's the best way to regulate the hospital. Another way to look at this is what's the best way to protect the patient, and to just say, here's the clear line, and there's going to be a pretty severe consequence in the form of like a class action lawsuit or something if that line is crossed. And that's not an extraordinarily common approach in this. Most state policies that we see don't have some sort of private right of action and don't connect these issues to the state like UDAP or Consumer Protection Statute, which I think is an untapped enforcement area. Washington's an example.
I have a question about co-pays and deductibles. To permit is to promote. Why are our health systems cooperating with the insurance companies so they can create a 23% overhead profit by not paying for health care? Isn't it time that our health systems refused to bill for deductibles and co-pays?
I'm from a provider, and I happen to be one of the rev cycle people, so I'm one of the villains in the room. But I have an interest in this stuff, and I can assure you that we would like to give more charity care. And I don't relish documenting this stuff. We have to because of Medicaid and Medicare policy, and we don't relish the role of asset test either. But that's a Medicare regulation as well. And there's too many lawyers that have given us advice, as was noted. But look, the it's not true. There's an asset test? Oh, okay. All right. Well, maybe we can talk afterward. For Medicare beneficiaries, yes.
We might be talking about the bad debt.
Yeah, I'm talking about the bad debt. Yeah,
might be Medicare bad debt.
Yes.
There'd be an asset test for if it's classified as financial assistance,
Right.
which would be different than Medicare.
Yeah, and we have to support those claims to auditors. Yes, but anyways, many of the payers require that we do not discount copays. There's nothing more that I'd love to do is discounts of copays, but it would be potential for inducement as well. But it's just we cannot do it because of the managed care contracts. We've tried to get it taken out, but there's just not an interest on the payer side to doing it. So.
All right, I think we have time for one more question. We have, whoa, I think Christine had a question over there for a while.
Thanks. I know everyone wants lunch, so I'll try to make this short. Christine Chen-Zinner with the Americans for Financial Reform. I just want to thank everyone on this panel. I know it's hard. You're like a perceived target, so thank you for making yourself vulnerable. I've learned so much this morning. As we're thinking about right now, the levers that are possible to pull to make change, the federal government seems a bit incapacitated at the moment, including Congress. Who knows? They might name a few post offices, but I'm not sure what other bills they're going to be able to pass. So it seems like, in an ideal situation, IRS, HHS would be able to lead and offer some more guidance on what's required and making sure there's like proper enforcements to make sure hospitals and other stakeholders are following the law. And apologies, but it seems like, I think as consumer advocates, it's easy to pick on the hospitals because they are kind of the point of sale, so to speak. So my question is really at this moment in time, it feels like the industry stakeholders are the most well-positioned, unfortunately, to make change. Maybe fortunately, maybe it's an opportunity. And I'm curious for the panelists up there, and I heard Eva start talking about this event she's describing for next week. Do you think there's any place where the industry stakeholders, and I'm thinking hospitals, can come together and agree to some kind of industry standard or good practice, maybe encapsulated in some kind of uniform form that folks can fill out to better understand who could qualify for some of this care? We know there's hospitals who aren't doing it. They're not being the Deepaks and the Freds. They're not being responsible. So I'm curious, what can the industry do to kind of fill in the gap at this moment in time?
Let me just real quick. I love what you said about the physicians, and that's been the probably most consistent pressure point that I've felt in hospital administration of wanting to be able to see people and make it simpler. So I think whatever form that gets overlooked, but to pull that group in, because most of them are employed now.
And then I would just add that beyond the industry, we should just note that the work of consumer advocates, particularly in states, have done phenomenal work in passing legislation, which I think that work is continuing, and that everybody's looking to the states to kind of, set the standard for helping guide some of the things like a uniform application, for example, right? That's something that can come from that space. I would also highlight too, like what LA County is doing, which I think is really phenomenal, and I think offers a model for counties and other states to look at it, how they're thinking about the arc of work and bringing in the hospital stakeholders as, as a partner to provide data and information around addressing this income issue. They're building their own kind of presumptive eligibility universe in LA County, and doing some extraordinary work to sort of think about making sure that they're the safety net of the safety net is how Dr. Shaw, who helps lead that work, talks about it. And then, yes, I think that there's also room for physicians to play and clinicians to play a really robust role, but we need more spaces for practice change. And we're hoping in our work with the Healthcare Anchor Network, too, that there'll be other spaces like that that can float and lift up some of those things.
Yeah. So locally, we passed an ordinance where hospitals are going to report their financial assistance and collections activities, and included in the variables that we're asking for, they're going to include if people were insured and who the insurance was, because now hospitals have always said denials are a reason why we go after patients. So if we see a trend in a particular payer being the issue, that gives us another lever that's not only going to help the patient, but the hospitals too, because we want you to keep your doors open. We just don't want the patients to pay the ultimate price.
I just want to add Maryland as well collects data through our Health Services Cost Review Commission on charity care, the number of applications, the number of denials, and through legislation in the past few years, there's a deep kind of granular demographic picture that is being collected as well in terms of how many of these are going to debt collection as well as charity care. But I love the idea of also looking at the insurance companies and adding that in and like seeing which ones are denying. And
All right, thank you all. It's time for lunch. Oh yeah, let's give the panel a great round of applause. Thank you all. Panelists, you can leave the mics on and just leave them on your chair. And we'll go to lunch, and we'll come back at 1 p.m. for our next panel on state policy.